Soma, Scalaxin, whatever one's individual choice is. You use antidiarrheals, you use sedatives for sleep, and you use anti-seizure meds. It's basically a full court press. You're very vigorous in medicating. The patient's greatest fear is that they're going to be uncomfortable. So the more you can do to take away the discomfort, the better you're going to do with the patient.
You mentioned lorazepam and that panoply of drugs that are used, Ativan. In your experience, do you find that those individuals who are going through withdrawal from painkillers, opioids, turn to benzodiazepines, supplement with the benzodiazepines?
Persons with well-established and active addictive disease are amateur pharmacists, and they self-treat. Ultimately, that's really what they're doing as an addict. And if they're uncomfortable, they'll take whatever they can get to make themselves comfortable. Many, not all, but many have experience with polysubstances of abuse.
What does benzodiazepines do for an individual?
They're tremendous at relieving anxiety.
All right. And one of the symptoms that you said exists in withdrawal from opioids is anxiety.
Severe anxiety.
Tremendous anxiety.
Tremendous.
Now, in addition to the drugs that are provided for detox, what else is done for the patient to try to make them comfortable, try to get them through this withdrawal period?
I think that's really it. Emotional support, psychological support.
Where is this detox usually held?
It can be anywhere, wherever the patient wants.
At home?
Buprenorphine, for instance, was created for office-based, i.e., home detox, home treatment of opioid dependency.
How long is it required to be on these drugs to get through these withdrawal symptoms? How long for opioids would it be necessary to stay on those drugs?
It's variable. So you need to reassess, reevaluate, and the medications that are used to treat withdrawal are, for the most part, not terribly pleasant to take because they're very sedating. And so when you have experience caring for someone in withdrawal, you develop experience knowing when they're no longer needing the meds. They've come to you to be comfortably withdrawn from the opioid, and so very often they'll tell you they don't need meds anymore.
Right.
But you can see the change in demeanor, in countenance. It's fairly obvious that you have someone who's become much more comfortable. And then, of course, if they're excessively sedated, you're going to titrate your medication doses down. By the same token, if they're uncomfortable, you might titrate your medication doses up. So you go with a ballpark figure, see how it works, and move on from there.
Is the period of now after the patient has gone to past the period of withdrawal, then what does the treatment consist of?
Primarily group and individual therapy, AA.
Are you familiar with a process known as rapid detox?
I've never done it, but I'm familiar with it.
What is that process?
It's the process of rapidly withdrawing somebody from opioid dependency using high doses of intravenous opioid antagonists. But it needs to be done under hospital care, general anesthesia, and ventilatory support so that the patient can be treated vigorously.
Why don't you do rapid detox? Why you not involve yourself in that?
Well, I believe in treatment, not just detox, so I take people under my care who want treatment for opioid dependency, which is multifactorial. It involves, again, individual and group therapy. AA, all of the social aspects of the addictive disease have to be addressed if you want to have a successful treatment program and plan. And rapid detox is just what it says, rapid detox. It's really not a treatment. It's just it's a risky way to stop using opioids.
And then the problem still persists.
Then you have, for lack of a better term, then you have a dry drunk.
All right. Tell me about the dangers associated with detox, rapid detox, or any detox. What are the physical dangers associated with that?
Well, since I'm more familiar with detox that is not quote unquote rapid detox, I'll start there. Again, the main dangers really come from the overactivity of the autonomic nervous system. Opioids lower the level of activity. When you remove the opioid, as I tell my patients to do by stopping it, the autonomic nervous system goes into hyperdrive, and that's what produces all of the symptoms of the withdrawal syndrome. And so you direct treatment at each of those symptoms.
All right. What symptoms, what types of symptoms could you expect based on that hyperdrive mechanism?
Blood pressure elevation, heart rate elevation, again, all the things I mentioned previously, sweating, severe anxiety, agitation, discomfort, crawly skin, abdominal cramps, nausea, vomiting, diarrhea, severe bone pain, and in its worst forms, you can see fever elevation and other objective somatic signs.
Now, let's talk about rapid detox for a little bit. That involves actually creating this, or stimulating the withdrawal process. Is that right?
Not my field of expertise or experience.
Do you know why in rapid detox programs they require ventilation, general anesthesia?
I would put it in the reverse order. They require the general anesthesia to tolerate the discomfort. If you look at an opioid antagonist product information, one of the things that it will say is that you can diagnose addiction by administering an opioid antagonist, because if someone is active in their opioid use, they will go into immediate severe withdrawal. So if you're going to administer that drug to someone who's admitting to you and coming to you for help for opioid withdrawal, you better be prepared to immediately ameliorate all of those symptoms. So someone invented, so to speak, the methodology of putting somebody under general anesthesia, and then therefore you need ventilatory support, which is why I put it in that specific order. And subsequent to that, you can infuse intravenously an opioid antagonist, and the patient goes into withdrawal while they're under general anesthesia.
One moment, please. Does one of our jurors need a tissue? Don't hesitate, Juror Letta. Do you have one, Mrs. Theodoro? It was on the side of Dr. Waldman. Could you give that to Mrs. Theodoro? You're welcome. Keep the box for now. Thank you.
May I, Judge?
You may.
One of the concerns with withdrawal or detox is our physical. Actually, one of the concerns is with the heart as well. Is that right?
Well, it's stressful. It's definitely a physical stress to undergo.
And it's stressful to the respiratory system? Is that correct? Which parts of the body would you say it was stressful to? Which systems?
Which form of detox are we talking about?
Rapid detox?
Rapid detox is stressful because you're undergoing general anesthesia. And general anesthesia and ventilatory support and assistance have their own mortality and morbidity, separate and distinct from the mortality and morbidity associated with opioid withdrawal.
And-
Again, they're necessary because that individual is about to experience an unbelievable amount of discomfort and pain. It could not be tolerated if you weren't asleep.
All right. What about ordinary detox? What stresses on what parts of the body, what systems in the body?
Primarily nervous system with anxiety and insomnia and cardiovascular. There's like any other medical problem or illness, there's degrees and variability, and a lot of it's very individual. So many people experience opiate detox but are not terribly uncomfortable, and some people experience opioid detox and are tremendously uncomfortable. It's extremely idiosyncratic. It's not predictable. The main stress is really, again, heart rate increase, blood pressure increase, but you're aware that those are going to happen, and so you're, so to speak, pre-treating them. You don't wait for someone to experience them. You provide medication proactively.
In addition to the variability of the symptoms, there's also variability in the length of time that the withdrawal would peak. Is that fair to say?
Yes.
An individual might, for instance, start withdrawal symptoms in 12 hours. A particular
Yes.
individual might.
Yes.
The peak may hit in 72 hours. Depends on the individual.
It get highly variable. And some people never really experience bad withdrawal. It's a very idiosyncratic individual thing. What makes it more challenging is that, again, people with addictive disease are not generally accurately representing their precise use. Some embellish it, some undervalue it, and so you have to be prepared that you might be over or under medicating.
All right. Now, when I came to see you, well, to hire you on this case, Dr. Waldman, we talked a little bit about addiction, but I also wanted you to review some information. Is that right? I provided you some information to look at.
Yes.
And one of the things that I asked you to look at were medical records.
Yes.
Is that right? I'm going to mark this exhibit as UUU, useful, useful, useful.
Triple uniform.
Could you spell that?
How many pages?
It identifies itself as having. Let me make sure that it's correct. Let me count. Make sure it's correct, Judge. That's all right. I don't want. I have 36 pages, Judge. I'm going to. That's what I've got on this. It doesn't say that on here, but that's what I've counted. 36 pages on UUU.
Thank you.
One of the things that I asked you to review, Dr. Waldman, were the medical records of Michael Jackson. Is that right?
Correct.
And these were medical records that were provided to us pursuant to subpoena from Dr. Arnold Klein's office.
Yes.
And I asked you to review these pages that were provided by Dr. Arnold Klein's lawyer and take and look at the treatment that had been given to Michael Jackson. Is that right?
Yes.
In addition to these medical records, I also asked you to review other things. Is that right?
Yes.
Statements from witnesses,
Yes.
testimony from witnesses.
Yes.
Now, I want to go to these records. I want to go to some specific days